Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as medical director of care management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussion surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today we have selected two intriguing cases to discuss. Dr. Rebecca Severe will kick us off by introducing our first case.
Great. Okay. Well, welcome. We're going to go through a case from one of our hospitals. I'll go ahead and just provide some background information on this particular case, and then we can pause and talk about what both of you would do. So the first case I have is a 66-year-old female who has a history of moderate COPD, is on HOMO2 with a baseline amount of 2 liters. This patient does have significant past medical history for a recurrent ovarian cancer and has active abdominal wall recurrence. This patient is awaiting a surgical debulking in a month. Also has comorbid conditions of diabetes and has a BMI of 40 with obstructive sleep apnea. The patient presented to one of our facilities with increased shortness of breath, had already been on outpatient antibiotics for sinusitis. In the emergency room, this patient was mildly tachypnic with respiratory rates initially 24 to 26, but that did improve quickly over a period of hours. Initially, the patient was on 4 liters with oxygen levels measured between 96 and 97%. Gradually, they were able to wean this patient down to 2 liters over the course of the first day, with saturations maintaining in the 90 to 94% range. And then on hospital day 2, this particular patient, they noted that she had dropped down to 89%. They had to go back up to 3 liters. The saturations at that point stayed 90 to 93%. And then going into the morning of hospital day 3. And then the notes, as we were taking a look at them, on hospital day 2 showed that the patient had some increased shortness of breath with activity. On the initial chest x-ray for this patient, there was some bibasilar infiltrates. A physician treating this patient did have this patient on antibiotics for possible pneumonia and then put the patient on a schedule of nebulizers. And so then I'll pause there. We had gotten, a denial on this case. What are you thinking as a physician advisor? This is the case you're given. You have a denial from the payer, and it is a Medicare Advantage payer. What are you thinking at this point in time? Is this something that you would probably go after in a peer-to-peer, or would you, think this is something that you're probably going to have to downgrade or rebill?
Yeah, Rebecca. So thinking about the case that you just described, very much not an infrequent case, so to speak, maybe a little bit of difference on the comorbidities, but I would at the outset, I would say that I would be one inclined to go forward with a peer-to-peer on this patient. And here's my reasoning.
Sure.
You have a patient who has shortness of breath, documented dyspnea on exertion, documented on after the first midnight, decreased oxygen saturations. You have requirements on the first calendar day, as well as the second calendar day, of an increased need of oxygen from the baseline. You have an abnormal chest x-ray, and you have a patient who is, by description of the medical comorbidities, not exactly the healthiest person to begin with. You've also got the added factor that there is a lot of work and resources being utilized because you have a patient that is getting antibiotics. And I'm assuming those were IV. Was that correct, Rebecca, that they were IV antibiotics?
Yes.
So you've got IV antibiotics, and you've got nebulizer treatments, which are either being administered by the nursing staff or by the respiratory therapist. Regardless, it is resource utilization, and that can be resource heavy depending on the interval for which they were giving them. So given that this is a Medicare Advantage patient, my argument would be this patient had medical necessity and it extended greater than 2 midnights. And there was a definite risk here if you sent the patient home, given all of the issues that I just enumerated.
Anything else that would be helpful that you would want to use for this case? Or
Rebecca, can I ask a follow-up question? What was the white blood cell count?
Yeah, the white cell count is 10.8. There are some additional labs that were obtained. The creatinine was sitting at 1.2 and with a baseline of 1. And then they did check the usual, for COVID, RSV, and influenza. They also did Legionella and strep pneumo, and all of those came back negative as well.
And along with shortness of breath, was there any cough, fever, something more to support the possibility of pneumonia? Because bilateral basilar, again, I know our goal is not to do a clinical management here or decision making, but still, whatever I could find to support, why are we worried about this patient having a pneumonia would be helpful, especially when we are going for peer-to-peer. We have definitely a 2 midnight medical necessity, but I can see why peers would still argue, to deny. So I want to be more prepared well ahead. What are my differentials and risks with that? Was the shortness of breath we were thinking is because it's pneumonia and it won't show like a complete true pneumonia like any other, because when this is a patient with a poor medical history in terms of the ovarian cancer and with already having the COPD, already being partially treated with oral antibiotic or sinusitis, and thus it's more of a complication? Or is it someone who we think with that ovarian cancer and giant mass is having shortness of breath because belly is way too swollen, has ascites that's pushing on to the diaphragm, and that bilateral basilar, because I want to be prepared. What if they say, oh, it's just could be atelectasis, right? And that this is all symptoms because of that. Fair enough, we have documented desaturation, but they like to see something below 88 for a COPD. So that's, again, I want to be more prepared. So we'd like more clinical information saying, even if we want to argue this is not slam dunk pneumonia, there is no white blood cell, because I've had good peer-to-peer where they're very thorough. They're like, how are you even calling pneumonia? There is no white blood cell. There is no fever. There is no sputum. You're testing.
Admittedly, Sweta, the leukocytosis here is not great. You said 10.9, Rebecca, is what you had?
Yeah, 10.8. Yeah. So up a little bit, but not impressive.
Yeah.
Yes.
Right.
Yeah.
Exactly.
And then could I, you were making kind of a differential there, Sweta. I think the other thing, I don't know if it was mentioned or not, but to be considered is if you have a person with metastatic disease, is this bibasilar atelectasis or bibasilar consolidations / what have you? I think you also have to wonder, is there metastatic disease causing what you're seeing in the chest x-ray and the change in the patient's perceived ability to breathe?
So in other words, I would definitely argue and go for peer-to-peer and share, like, because sometimes I can see how they can argue on specific diagnosis, but keeping in mind that we don't even keeping in mind the differentials and things we are considering, and we have to work it up and figure out the plan for each one of them is equally important, is my point here.
And I think, this case to me, like if we're just using the 2 midnight rule, which it's a Medicare Advantage plan that did happen after January 1st. So the 2 midnight rule, should have been in effect for this case. And to me, it seemed obvious that there was clear medical necessity for that second midnight. We had a patient with ongoing desaturations. The one that I did mention that was also going on because of this large abdominal mass as well, and that was, not yet treated. She was going to be undergoing a surgery. She was having some abdominal pain. They were giving, multiple doses of IV pain meds, 2 to 3 per day, going on hospital day 2 and even into hospital day 3. All of that to me supported, ongoing, medical necessity for hospital stay. Now, the pair I had the discussion with that day was not quite seeing it that way. It was still very much a conversation around, based on looking at criteria for a particular diagnosis. I had to fortunately go down that pathway to try to make the case, and not just simply that, given all of this complexity, this was a patient appropriate hospital level of care. So, where I ended up getting the case, overturned, I did focus in on pneumonia. I went after the pneumonia because this was a patient that they treated like pneumonia. I said, they treated it like pneumonia. They didn't treat it like a, pure COPD exacerbation, because initially that was where they were, the pair was pushing back and saying, we're denying because it doesn't need inpatient for COPD. And so I said, well, they're treating this for pneumonia and a patient with persistent hypoxia, acute on chronic hypoxia. And so I was able to get it overturned, but I really did have to, focus in on that diagnosis. So I know, Sweta, you were going there with like really trying to tease it out. I know it's not, like this rip-roaring, nice, right lower lobe, infiltrate, high white cell count, fever, sputum. It wasn't textbook, but nevertheless, they were treating this patient like she had pneumonia. Again, we're not that bedside physician. So I did have to kind of push back a little bit and say, hey, this is what the bedside physician called it. This is how they treated it. There were no IV steroids. It was just, some maintenance meds and really focusing on more of a pneumonia treatment. So, any other thoughts or comments?
I just come back again to asking myself the 3 cardinal questions I always ask, which was, is there medical necessity, which we've already discussed the reasons why we think it's so. Is there severity of illness? And for this patient, for multiple comorbidities, the ongoing cancer, the possibilities of the differential diagnosis, yes, there is clinical severity in her dyspnea on exertion, her need for more oxygen, and the potential risks involved with what would happen had she left without treatment at all, or if this continued to be attempted with PO antibiotics as she had been receiving as an outpatient. And then finally, I also look at what is your utilization of resources. And I think I made this point earlier. I think there's a clear utilization of resources here, given that they were treating her as a pneumonia patient, giving her IV antibiotics, giving her frequent nebulizer treatments. And then, as you point out, you had other issues like IV pain medications that would go to that resource utilization. So I'm glad you were successful in this case, Rebecca. And it is very frustrating when you feel like criteria are being used in the peer-to-peer discussion, because in my mind, the peer-to-peer is a time for 2 physicians to really talk about the patient's medical condition more than it is to cross off X out boxes.
Yep. I appreciate your comments, and it's always an interesting discussion.
Thanks, Rebecca.
You're welcome.
Thanks, Rebecca.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acma.org/membership to learn more. Let's continue with our second case.
Teresa, you want to go ahead with your case?
Sure. I have a case for you guys today. This is a 74-year-old female who came into the hospital complaining of dizziness, headache, and just not feeling well at all. And she had a head CT on admission that was negative for any kind of hemorrhage, bleed, etc. Her laboratory studies revealed a sodium of 121. Now, hyponatremia is not foreign to this patient because a review of her record showed that a year prior she had a sodium of 129. But the 121 was fairly significant. Of note, the patient had had a change in her hydrochlorothiazide dose that she received because she is a patient with a comorbidity of hypertension. Her other comorbidities are chronic kidney disease and hypothyroidism. So the patient was admitted by the provider with concern over whether or not the thought was it's SIADH that the patient was experiencing secondary to hydrochlorothiazide changes in medication dosages. And she was admitted with anticipation of free water restriction. And let's stop there because there was something that also happened on hospital day number 3. But I would ask you guys, given what we know and are trained in medical school about hyponatremia and its correction thereof, would you have expected this to be, and by the way, this was a Medicare Advantage patient, would you have expected this to be a 2-midnight stay such that you could invoke the idea that we've met or will be meeting those particular criteria? Rebecca, what do you think?
Especially with these patients that kind of have a little bit lower sodium to begin with, they oftentimes will, go down to the lower 20s. They don't always have a lot of symptoms, a little weak, some mild symptoms. And without doing a lot, oftentimes they will correct pretty quickly. So it's one of those to say, in my experience, even though we might want them to correct a little slower, they tend to not correct as slow as we would like them. So I'm a little bit on the fence. Is it a clear 2-midnight expectation? It's maybe I would have to see the patient in front of me. So it's one of those that I know I sometimes for those low sodium cases when I'm the clinician, will start them out as observation to kind of see where they're going the next day on hospital day 2. And then if they need to stay, if they're taking, longer, then I will, definitely, want to get them upgraded. So,
and Sweta, I know our concerns are pontine myelinolysis or extra pontine myelinolysis for rapid correction beyond. I'm not sure what the current medical school teaching is, but being neurology trained myself, I can tell you that I don't like it to see it any faster than 0.25 to 0.5 milliequivalents per hour. What you're thinking about how you would come down on the idea that it's going to take, if done correctly, at least 2 midnights.
So again, I want to see, so when like Rebecca said, it's very, sometimes these hyponatremia patients can be a little hard to decide just based on one value. What's helpful to know is that the patient has had hyponatremia, but even then it was like 129, more closer to 130s than someone who's like cirrhotic and heart failure who stay around 125. So if it goes from 125 to 121, I would be more okay, but 121 compared to 129 year ago, that too in a setting of an HCTZ, the hydrochlorothiazide, that even when we correct, I would need to decide on the medication dosing. have to monitor on that to make sure it does not keep. And like you said, when correcting, even though they are at risk of correcting too fast, we like to monitor them and do Q4 hour sodium checks initially to make sure they don't correct too fast, and to make sure they're correcting. Because sometimes if they correct too fast, we give them D5. Try and make sure they don't correct too fast because of the potential risk, right? So I do see the utilization of resources. Even though we are not doing anything IV, half the times we are not giving them hypertonic solution, or because the plan here in the setting of SIADH will be fluid restriction. So there would not be any IV medication need, but there is definitely close I's and O's monitoring, intake and output monitoring. We want to make sure this patient does not drink too much free water. We want to get the lab every 4 hours to make sure sodium does not correct too fast. And again, at the rate we would like it to be corrected, there is an expectation that this patient will end up staying greater than 2 midnight. First midnight would be for slow correction of the sodium. Once corrected, we have to make a decision on the dose of the medication or manage the blood pressure, or if we want to just change it, add something else. So I know these are a little bit tricky and hard. Do we want to start at observation and switch them to inpatient next day? Or clearly this is 121, way low risk of clinical decline and risk of patient. So given the utilization of resources, I would be comfortable saying we can start as an inpatient too.
Give you guys some more information here. So in the first 24 hours, her sodium went from 121 to 127. In the next 24 hours, she went from 127 to 129, the calendar days roughly. So by the third day, she had corrected up to 131. But also on the third day, she began to develop vertical nystagmus, such that a stroke code was called. And the neurology people came to evaluate her. And she then admitted that she had had a fall 4 days prior to her admission because of the dizziness that brought her to the hospital. And on that second hospital day, nephrology was also consulted because of the thought of the SIADH. And they actually felt that she was correcting a good fashion. So they switched her laboratory studies over to Q12 hours, and they decreased her restrictions from 1 liter up to 2 liter. And they also ordered an MRI scan for her. Does that give you any other information that you would utilize to argue, Rebecca?
I definitely think, this patient has ongoing symptoms, which helps her case. I think the hard part is when they come in, they get a liter of fluid, 500 in the ED, and very quickly their sodium comes up, sometimes in a few hours. You don't want it to happen, but it does. And they don't have symptoms, and the next day they look great. So I think those are super hard to get overturned if you typically get a denial for it. This patient, however, they, is having more symptoms. And I think that's certainly where I would play on this case to help support that there was concern. My goodness, we're calling a stroke alert on this patient. She was altered enough that there's more going on with this patient. So I definitely, if I'm trying to justify this case, I would also reach out if this was a very bland case, like looking at the notes, and I wasn't seeing much, but then I got word from the nurse that we're going to do an MRI. I would also want to make sure I connect back to the physician and say, hey, I heard you're doing an MRI. What are you worried about? Especially if that's not in the chart. Because I think that's another way you can help strengthen a case like this. Because sometimes there is something going on. It's just the notes you can't tell. The physician advisor, I can only see what's written. So that's another pearl that I use.
I agree.
Sweta, did you want to tie us up here with any further thoughts about the case?
I was going to just say that I agree with Rebecca that getting more into what are they thinking, what are their differentials, and especially with things which are high risk of morbidity, mortality. Those we are worried about would be helpful to know. Like you rightly said before, looking at the 3 things. Is there severity of illness? Yes, and the patient since has continued symptoms, if anything worsened, to the point requiring stroke code. So there is utilization of resources, 2 check boxes already met. Third is a medical necessity. Even though patient had a good recovery for the sodium or good trend, still Q12-hour lab checks are not feasible in an outpatient setting. There is still need for monitoring and correction. So I think we've met all the 3 checkboxes and continue to support the inpatient level of care for this patient.
And I can tell you that we won this case on peer-to-peer. And I think because of all the points that the two of you have just made, and the patient ended up going home actually on hospital day 4 with the MRI not revealing any evidence for myelinolysis or any acute stroke, that it was a combination of factors likely for her. So
did you get a lot of pushback on that with the negative MRI? I mean, I know it shouldn't have because we had the medical necessity there in the time frame, but I know sometimes you still get that. Was that part of the discussion or not?
Yeah, they didn't bring it up. The fact that we had an acute stroke code called, that neurology was phoned in some special consultation urgently, that an MRI imaging was further recommended. I don't think it really mattered at that point in time because we were going over the 3rd midnight at that time. So I think we well met our burden of proof for the 2 midnights of medical necessity. But yeah, I can see how if that would have happened on day 2, then a negative MRI scan might have given whoever the payer's medical director might have given them an ability to push back a little bit harder.
Yeah.
Great. Thanks, guys.
Thank you. Those both cases were very interesting and I learned a lot. Thanks for bringing them today.
Okay. Thank you.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Doctors Severe, Singh, and Jacobs for sharing these interesting cases in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.